Everybody?
1 minute, Margaret.
Okay, sorry.
Let's see if everyone's joining. Okay, thank you. Please go ahead.
Good afternoon, everybody. So good to see so many people joining us for this webinar of the ESPGAN. My name is Margaret Wessels. I'm a pediatric gastroenterologist from the Netherlands, Arnhem, and I'm one of the members of the steering committee of the special interest group in celiac disease. And I'm very honored to have two speakers here who will talk to you about the gluten challenge. And I will introduce them after I've said something to you as attendees, because I would like you to be as much involved as possible by asking us questions and to ask these questions in the chat. I will moderate this session, so afterwards I will ask all your questions to Alfonso and Francesco. And we'll do the questions once their talk is finished. So then you know how to put your questions forward. There will be two presentations. The first one will be held by Alfonso Rodriguez Ferreira. He will talk about why to challenge, when to challenge, and who to challenge. And the second talk will be done by Francesco Valitutti, and he will talk about the how of the challenge, so the practicalities. So first, I will give the word to Alfonso to take us through the who, when, and why. So Alfonso, please tell us everything you want to share with us.
Hello, Margaret. Many thanks for your kind introduction. So I'm going to share my presentation now. Let's go here. No. This is about a few questions about the why, when, and who to run a gluten challenge. That is some questions we have to answer when we are facing this. So there will be like an introduction to the practicalities that Francesco later will be explained. That his part is the really interesting part. So what's a gluten challenge? Gluten challenge is basically a diagnostic tool used to confirm or exclude a diagnosis of celiac disease. It's a resource that we have. Why to challenge? That's a very important point. So celiac disease must be formally diagnosed because it's a lifelong autoimmune condition with significant medical, social, and personal implication. So it's not something that when it happens, it's going to be disappearing in a few weeks for the whole life. And that can be conditioning what that family is going to be able to do about traveling, attending certain school, or also the professional career of somebody later. So an accurate diagnosis is critical to ensure proper management. So we are going to be having a special diet for the rest of our life. They have to be based on a well-proven diagnosis. Also help to avoid unnecessary dietary restrictions, so people can go easily on a gluten-free diet, and if that is not really well indicated and really well supervised, they may be running into dietetic or nutritional deficit in the long term. Legal and social recognition, so to be having access to support or prescription or some funding help in some countries, they had to be having a proven diagnosis of celiac disease. And sometimes when that diagnosis is not possible to be done, gluten challenge is a tool to be used. Also, in some cases, reinforce the compliance. So the formal diagnosis ensure that this challenge are addressed with appropriate medical, dietary, and psychological support. About the gluten challenge, At present, the use of the gluten challenge in celiac disease is not very common. It's a resource that we use time to time, but not on daily basis. In the old days, I have to remember that was part of the formal diagnosis of celiac disease. That's gone long time ago. It is recommended for a child or for children who are suspected of having celiac disease but do not yet have a confirmed diagnosis. So if the diagnosis has been already confirmed, there's no much indication for a gluten challenge. The problem is that because given the limited data to support an optimal gluten challenge, shared decision making with the family and child are essential because there are different options and different lengths. I think Francesco will go deeply into that point. Why to challenge? Because the gluten-free diet was initiated before this celiac disease diagnosis was confirmed. That's probably the main reason. Because we have a discrepancy in the results, such a positive celiac autoantibodies in the absence of duodenal enteropathy, or because symptoms in the presence of gluten without positive serology are there. Some people may experience symptoms, and we are not sure if they are triggered by gluten or by lactose or by proteins or anything different. When should not take the challenge? So there's some classic pediatric consideration to this point. Gluten challenge should be avoided during periods of accelerated growth, classically before 5 years of age, prior to the formation of permanent dentition, and during the pubertal growth spurt. But not everybody is on agreement with this point. Some authors think that patients who have a minimal to no symptom of normal growth may undergo a gluten challenge at any age. They argue that because these children may be having a dietary restriction or a not well done follow-up, a gluten challenge may clarify the situation and prevent more future difficulties or more restrictions. They think there's not much risk if the child is properly supervised and they are not on a faltering growth situation. About the when, how long to challenge, that's an important point. Because many patients are reluctant to partake in the gluten challenge because of the evident risk of developing discomfort. In a family where having a child who went through plenty of symptoms, with a lot of pain or having diarrhea, they may be scared and they don't want to be proposed something that's going to be lengthy. So the risk here is they're going to try to be on a gluten challenge for a very short time. A gluten challenge should not be carried out for just a short period. Just a few days in gluten is not going to be valid. Need to be done for a longer time, and Francesco will speak about that later. Severe symptoms can appear after gluten has been administered before serology turns positive. So before having in the follow-up a positive TTG, may happen that the child is going to present abdominal pain or vomits or nausea, and the family may be tempted to interrupt the challenge. That had to be explained in advance to prevent this happening, that they had to be on the gluten challenge also if some symptoms happen, because that symptoms will probably disappear later. There will be some kind of clinical tolerance, and later the positive test in blood tests will be happening. In most studies, only a few children respond by symptoms to a low or high gluten dose during the first 2 weeks. So the importance about go for a longer period of time. Where or who supervise the challenge? I think we have two sides here. One is the healthcare professional side, the vision of the doctor, nurse, or the dietitian. There is no clear evidence about the setting in which a gluten challenge should be ideally conducted. Some authors, like this paper published by Luca Eli and his team, state that they can hypothesize that the challenge should be performed in tertiary centers, but there's a limitation of accessing this center, and it's really difficult in many European countries and outside Europe. Probably what is really important about the where is not the place, is the team. More important is that the gluten challenge had to be performance centered with a formal protocol where this protocol can be formally followed and having, as member of the team, gastroenterologists, pediatrician, allergists, or dietitians. And they have to be available to be contacted if something is not going as we expected. So the where is more related to a team than a physical space. It's possible to conduct a gluten challenge primary care. In theory, it will be possible if you have the proper team supervising the situation. If you have a tertiary center and you don't have a dedicated team to follow celiac patient, also being a reference center would be not the right place to conduct a challenge. What the SGAM says, what the SGAM say that should be performed under the supervision of a pediatric gastroenterologist. That's what the guidelines say. But they say there's a clear limitation to access pediatric gastroenterologists in many places around the world. They are in high demand and in short supply. There's another side of the supervision of the challenge. This is the patient side. Family expectation during a gluten challenge can vary, but generally families should anticipate, and this had to be explained before the challenge. It's something they do in the clinic. They need to know what's going to happen, what is expected to happen. One, the individual may experience a return of symptoms. Some people feel really sick, some people are not to be feeling sick, but in both cases, the challenge had to go ahead and had to be progressing. Adjustment requires careful planning of meals. Remember that the challenge can be happening in a family that was previously explaining the child that should be on gluten-free diet, and now we're asking that child to have gluten again in the diet. And may happen that in a third step later, this gluten is going to be removed again. So all the meals had to be supervised, and the family had to reflect about these different steps and how they're going to deal with the situation. If not, it can create lots of confusion. Emotional support. It can be physically and emotionally intense. Fear to induce symptoms. Some families say or have told to me is I was feeling like poisoning my child. And that put a lot of stress, because this stress can have a kind of nocebo effect also during the gluten challenge that have to be taken into account. Regular communication with healthcare professionals is crucial to address any concern and to adjust the challenge protocol if necessary. The family had to know they can access the doctor or the dietitian or the nurse if something is going not really well, or they have doubts, or they don't know how to do. So this support, having identified by some of the family as the key part of the challenge, be able to get help if something happens. They also have to know what to do if the symptoms are very intense and when they have to attend again to the clinic. Finally, and to have time to discuss this and to give more time to the really important part of the presentation today, that is Francesco's presentation, some take-home messages. Gluten challenge remain a crucial diagnostic tool, especially for confirming or clarifying celiac disease or determining the need for dietary restrictions. The procedure and its necessity must be tailored to each child, clinical history, and diagnostic needs, and the family had to be involved in the whole planification of the process. From my side, that's all I think will be a good introduction to the really interesting part that Francesco is going to present now. Thank you for your attention.
Thank you very much, Alfonso. There is one question that came in already in the chat, and that is whether the guideline recommend a gluten challenge until the celiac disease is diagnosed. Can you answer the question?
I wondered, they who asked the question really want to know if it's recommended to stay on gluten, or it's recommended you have to stay on gluten before, but it's not needed to go into a higher dose of gluten or create an overload of gluten. That is not needed anymore. but you cannot remove the gluten before having a formal diagnosis. That would create a lot of confusion.
Yeah, I think you answered the question excellent. It's not that we perform a gluten challenge, of course, in everybody, but you have to stay on gluten to have the diagnosis done. And maybe you can explain what happens if people take too much gluten. What is too much gluten? What happens to them?
Well, it may happen you're a celiac patient, you overload like was done in the old days. You can trigger a really, really bad situation, what's called a celiac crisis in the old days. But the main important point here is some family, I don't know if that happened to you in your practice, when they hear that the gluten can be a problem for the child, they are tempted to cut the gluten. So we arrive to the formal diagnosis, and then the markers goes down, and in some cases also when they are facing a biopsy, can be confusing if the gluten have been removed and you are not aware of that. And all happened because the fear of damage your loved ones. So that's why a conversation is so important. So please insist on keeping the gluten in the diet. And second, no need to give more gluten, to give more bread, more pasta before completing the diagnosis.
Yes, I think this is very important to stress. It's a good point that you brought up, and in that sense, also a good question. So there, and you are thanked for your advice, Alfonso, by the person who asked the question. So when there are no other questions coming in for this talk, let's continue with Francesco. And maybe afterwards there will be questions coming in for both of you. So please, Francesco, tell us everything that you want the audience to know on the practicalities, how to do it.
Thank you. Thank you very much, Margaret, for your kind introduction. I have to thank the steering committee of the Special Interest Group for Celiac Disease for asking me to give a presentation on how to run the gluten challenge. And I also have to thank Alfonso for his clear presentation, which perhaps create too much expectation about my talk. So this is the presentation outline for my talk. I'm going to review the ESPGHAN position paper recommendation on how to run a gluten challenge. I probably will lose some of you in the evidence behind those recommendations, and then we will end up with the take-home messages. So when I started the search for this talk, I realized that there was a biphasic interest of the scientific community for the gluten challenge. And this was quite clear because in the old days, the challenge was necessary to confirm the diagnosis of celiac disease where we didn't have any serology available. And in the modern days, the challenge has become more frequent in the literature as regards the alternative drugs treatment trials. So that's what is behind this interest. So the ESPGHAN position paper on the management and follow-up of children and adolescents with celiac disease have a few statements about how to run a gluten challenge. I start with the second one because the first one has been covered by Alfonso. So gluten ingestion of 10 to 15 grams a day for 3 to 6 months is expected to induce small bowel abnormality in the majority of celiac children, and optimal amount of daily gluten intake and the shortest time for an effective gluten challenge are still unknown. So when we plan to perform a gluten challenge, it means that we are doubtful about a diagnosis, and the intestinal biopsy may be considered at discretion of the clinician at the beginning of the challenge. But as you can see, there is no full agreement of this point by the experts. Where there is instead full agreement is that to avoid unnecessary exposure to gluten in celiac children with an early response to the challenge, we should always perform serology 1 month after starting the challenge, because sometimes it might be that you have already some dynamics of the antibodies. But this should measure, if negative, every 3 months during daily ingestion of 10 to 15 grams of gluten for 12 months, because there may be slow responders. And this was fully agreed by the experts. In case of symptoms suggestive of a CD or the appearance of the antibodies, small biopsies should be performed, and this is the agreement is not very high because it depends on the serology, but still, if you are in the case of a gluten challenge, it means that there was a doubt about diagnosis before. Again, in the absence of symptoms, a specific celiac disease antibodies after 1 year of formal gluten challenge with high gluten amount in the diet, the child should be allowed to have a normal gluten-containing diet, and the follow-up should be counseled and proposed on an annual basis. An earlier evaluation is recommended in case of suggestive symptoms. So when we have to unveil what's behind this gluten challenge, I have been through a journey, which was a fascinating journey into the history of celiac disease. At least this is the first paper I was able to track about gluten challenge, which regards a cohort of children from Sick Children Hospital in Toronto, 23 children with proved celiac disease after the initiation of the dietary therapy, and 13 of them had a normal duodenal biopsy at the second biopsy, so they were to be rechallenged. And only one of them had the development of symptoms earlier in the hospital. They performed a challenge within the hospital for 6 days, and they performed a very early biopsy after 6 days, finding no alteration. And when they kept this patient on a follow-up and they studied them after 12 to 15 months, all of them developed both mucosal lesions typical of celiac disease. So what does this mean? Is that the response to a gluten challenge is not straightforward. You cannot expect very early, and perhaps many times you have to wait along. But how long? It was seen through the literature in other papers from the late 70s. This is a paper from Great Ormond Street colleagues who challenged with the 10 gram of wheat protein, which means 8 gram gluten, 30 children for at least 3 months. And as you can see, when some of them had symptoms before the 3 months, they scoped them, and they found in only one of the 2 that were, or the half of the 7 who were scoped, some alterations. But many of these children showed alteration after 3 months on a gluten challenge, and only 6 of them were kept on a gluten-containing diet because there was no relapse at histology. So one thing that came out from the literature is that there could be a different behavior from the challenge performed in children and in adults. You can have an earlier response, an earlier mucosal relapse in adults compared to children. That's what this paper showed. The first let's say, marker of relapse has been shown to be the infiltration of T lymphocytes into the mucosa. But when looking for early predictors of relapse, some group, the group of Naples, realized that sometimes AGA and Xylos mannitol test could help in this situation. Of course, we are in the old days where serology was not available, and in this paper where they performed challenge with 10 grams of gluten power on 31 children, 21 of them relapsed after 2 months, and 9 of the remaining relapsed after 7 months on 10 grams of gluten per day. So this is a talk for people interested into celiac disease, but we should always remind that if somebody of the audience is quite naive, we are talking about a huge amount of gluten, which in celiac patients, lower dose could definitely cause damage, as it is being shown also by studies on challenge with less gluten amount. So this is the first paper where serology comes into our stories, early 90s. This is still the group from Naples. 10 grams of gluten were given daily to children with doubtful diagnosis. And as you can see, in a time frame between 1 month and 3 months, lots of these children develop positive anti-endomysial antibodies. Another group from Sweden demonstrated that, and this is quite interesting because they were one of the few groups who performed a challenge with the gluten dose depending on the weight, that even lower amount of gluten could develop antibodies over time without any difference between the group. What was different between the group is that the higher gluten amount, the more severity enteropathy score, which was a combination of infiltration of intraepithelial lymphocytes, decrease villus height, creep depth ratio, and higher enterocyte damage and more infiltration of lymphocytes also in the lamina propria of the mucosa. Still another group from a Scandinavian country demonstrated that the more lymphocytes infiltrates, the more gluten is needed on a daily basis. This is a study where anti-transglutaminase antibodies came into our story, the story of gluten challenge. And as you can see, this is a study from adults. As you can see, the response of anti-transglutaminase during challenge is more erratic compared to what happens on a mucosa level. So they are not a good predictor of relapse, at least in a short time. This is still a study from adults which took into account the diagnostic yield of mucosal lesions, anti-transglutaminase antibodies, and the combination of them. And as you can see, when you have both the anti-transglutaminase rise and the mucosal alteration as MASH3 score, you have a diagnostic yield of 84% on a CD diagnosis. And of course, the higher the gluten introduced, 7.5 grams compared to 3 grams per day, the higher response, as you can see from the lower cartoon in the gluten challenge. This is a very nice systematic scoping review about challenge and in celiac disease. And here we can see how the EMA antibodies perform during challenge, depending on how much gluten the participants of the trials were assuming. It might be quite confusing to read this table, but on the ordinates, you have the responders of the EMA. On in the lower part, you have the months of gluten challenge, and the numbers close to the figures are the amount of gluten that were administered during the trial. And as you can see, the higher the gluten, the best response in terms of EMA positivization in a time window of 4 to 6 months. This is the study from Ilma Corporani Zabo group who showed that on a quite high amount of gluten for children, 5 to 10 grams of gluten per day, you have EMA positivization in those who are celiac in roughly 70% after 3 months and 90% of children after 6 months of challenge. This is a study which compared the antitransglutaminase and immune response during challenge. And as you can see, after 3 months, 12 weeks of challenge with 2 to 3 pieces of bread, let's say roughly a little bit less than 10 grams of gluten per day, you have the positivization of both EMA and antitransglutaminase in children challenged for celiac disease. When we have, this is data coming out from gluten challenge trials preliminary for drug therapy. Of course, the villus height trip depth ratio is one of the first alteration that we might see on a very early biopsy on a gluten challenge. And it is still dependent on how much gluten you assume. You can see that there is no difference in villus height trip ratio on a day 15 when you consume, when adult patients with celiac disease consume 3 grams of gluten compared to 10 grams of gluten, which does influence the villus height trip depth ratio. In this trial, it has been evaluated also the response of some biomarkers such as IL-2, which is a very early marker of response to gluten. And this has been correlated also to the symptoms arising during the response. Vomiting is strictly correlates with the IL-2 response. This has opened the way for a lot of studies of translational medicine on how different markers could be used in the challenge, but we will probably need a different talk on this to go through all of this paper. One thing every one of us should be aware is that all the challenge are performed with trichum hexaploid wheat, which has a high amount of gluten, and we should theoretically, given this in vivo response, discourage a response with different kind of cultivars, such as Trichum monococcum, which having less gluten could elicit a reduced immune response. So I am finished with my talk. I go just through what has been published by the colleagues from the NASPGAN, a clinician guide to gluten challenge. It's an invited review from the end of last year on JPGN, and they stated, echoing also the SPGAN position paper, that longer duration, longer than 12 weeks and higher dosing of gluten might improve the diagnostic accuracy of celiac disease in children. And this is just to sum up, to give an estimation of how much gluten is in each food that we could propose to our families. For example, white bread, let's say 100 grams of white bread contains an estimated gluten content of 5 grams, and 140 grams of pasta, which is a normal portion, contains 6 grams of gluten. So just to give a roughly idea on how much gluten there is in each food. And the colleagues from NASPGAN proposed this algorithm, which is quite useful, and we could discuss on its appropriateness. So when we plan to have a gluten challenge, we assess the gluten intake, we obtain initial CD serology, because we might find also cases where the serology is positive and we don't need to do any challenge at all. When we have doubtful serology, of negative serology, HLA could help us, because if negative, it is very unlikely that we are in front of a celiac patient. If the HLA is positive or unknown, we should counsel for an intake of gluten, which, according to our colleagues, should be lower in the first 2 weeks, because higher amount trigger more symptom, which could also causes more dropout to the challenge protocol. And so if we start with a low amount of gluten and we provide check-in after 4 to 6 weeks, having a serology could be a good starting point. And we should consider increased gluten dose in those who have tolerable of no signs or no symptoms at all, to have a better diagnostic yield after 3 months. And we should consider doing serology, at least, of course, I've said after 1 month, but follow-up serologists in the months ahead, and consider an endoscopy after 6 to 12 weeks, especially earlier if there are intolerance and important symptoms arising. Thank you very much for your attention, and I'm open to questions.
So thank you very much, Francesco. There was a question from the audience, and it says, do you think it's ethical today with the well-known serology test to perform a gluten challenge?
Well, the gluten challenge it has to be performed in doubtful cases where having a child on a gluten-free diet, which might not be needed because there is no diagnosis of celiac disease, is, I think, more unethical than performing a gluten challenge and confirming this with a biopsy.
I have the same opinion. So the gluten challenge is a tool with limited indication. It's not for everybody. So there are actually very few cases that we are going to conduct a gluten challenge in the daily practice against the very old position years ago to practice on everybody. Will be no justification to systematically perform gluten challenge on every child. That's it. But remember, the patient had the right to be properly diagnosed. And that, in that case, in very selected cases, very confusing cases, is when the gluten challenge have a role.
Absolutely.
I totally agree with you. And the serology, it performs very well, but it is driven by the amount of gluten that you eat. So the gluten challenge is only necessary if you don't eat gluten beforehand. So I totally agree.
Well, in the years to come, we could have new markers which could allow us theoretically to have a very, very short exposure to gluten and still get into the clinical practice. But there is still to work on it because they are not ready to be released in clinical practice.
Is it possible to have a guideline for gluten challenge? That's another question coming from the audience. Francesco, you told us, you showed this very nice clinical guideline, or guideline for clinicians by the NESTCAN. Do you think it is also a good guideline for us in Europe as well?
Well, I must say, probably we could not have a guideline, but we should be aiming for a position paper, if any, because of the evidence is quite, I've showed what I found, but it's still too, in my opinion, too less to have a proper guideline. But a position paper could be an idea. And is it really needed apart from what we have already stated in the follow-up? I don't know. I would wait for more biomarkers to come into the practice, and perhaps this could expand our territories, and this might bring into the discussion and the need for a proper position paper on this topic could be needed. But for the time being, I think we should stick to the recommendation of the follow-up, which, in my opinion, are effective and work.
There's another question coming in. I will read it. When serology is transglutaminase 10 times higher than above range and celiac disease is diagnosed with this, if after 4 years the child still has transglutaminase of 11, which is a bit higher than a negative level, what should be done? So this is not a question on the gluten challenge, but it's more on the follow-up. Alfonso, do you mind answering this question?
As you say, that's a question more about the follow-up. One is, for example, check if the kit used is the proper kit. So it can be a problem with the lab, with the quality control. I say that because that happened to me in a couple of occasions when the lab changed the kit. So we have this kind of borderline positive. Second, check the adherence and the compliance properly with the dietitian supervision. Or in some places where that's available with the gluten immunogenic peptides in urine, because compliance can be behind that. And third, check there's no other autoimmune situation that can be giving you a false positive or slightly elevated value. But is, as you say, it is not. It's more about follow-up than about the gluten challenge.
Yes, I agree. And we know that there are some children that take longer. So you have to consider all these things that you're saying, but there are also children that take a longer period of time, and 4 to 5 years is not uncommon. And I think what's also important is to see the level of antibodies still going down. It shouldn't be in a flat line. Do you agree, Alfonso? It shouldn't be 11 for like 2 years. Then you start wondering what is happening
Right.
here.
Exactly.
Francesco, I had a question myself. Do you use gluten powder or only gluten-containing meals? What is your opinion on this?
Well, I have been using gluten-containing meal for children, but in adolescence sometimes I've used the gluten powder because I didn't want a very high nocebo effect. But this is just personal experience, and I've managed to do a kind of blinded challenge in the adolescence with the mom and dad aware of where they were administering, and it downsized the symptoms and allowed the challenge to go ahead.
And Alfonso, what do you do? Do you use powder or only
No, I
gluten-containing
usually
meals?
use meal with the powder. I only have used powder in research basis in the past, but on the clinical practice is meals. It would be not easy to get the powder in some places or location, and it will be more difficult to supervise there.
Okay, and then there's one other question coming in. Is with also for starters a compliment on our informative lecture, but the question is whether there's any possibility to reintroduce gluten-containing foods after 3 years of serology normalization and no more symptoms.
My opinion is
Alfonso.
usually no. I only have done a challenge in a similar situation where a very smart teenager girl came to the clinic and say, I've done my homework. I was diagnosed very young. I've been compliant, but I think I'm not celiac. I want to go under a gluten challenge because if not, I'm not going to continue with the diet. So will be a situation similar to that. Somebody who's doing well for a long time, all controls negative, that she wanted to know. And that case, finally, unfortunately, she was celiac. It was confirmed later. But I don't see a reason to test everybody re-exposing to the gluten challenge if they are doing well. Only if for some particular reason that family, that patient wants to go into the challenge will be something to discuss, but case by case, and always balancing risk and benefits, pros and cons.
Yes, so this is actually not a gluten challenge. It's more a confirmation of the diagnosis which is needed by, for example, this child, like you explained. Yes, I agree. Okay, are there any questions coming in? I don't see any other questions coming in. So then I think we are closing this webinar. I would like to thank you, Francesco and Alfonso, by giving this presentation. I would like to thank you as audience to listen to the webinar. And I would like really to draw your attention to the other webinars that are given by the ESPGAN as well. So please take a look at the website. And before closing, there's one more question coming in about the diabetics with a high transglutaminase and no symptoms with normal biopsy. How often do you challenge? Francesco, you might be interesting in answering.
Well, how often I challenge. This is a potential celiac disease diagnosis. Even if the high antitransglutaminase still makes me be a little bit skeptical about the histology readout and the number of biopsies and the orientation of biopsies. But still, with the non-symptoms, I will not do challenge. I will not start a gluten-free diet at all. So this is not a challenge. It's not.
You
It's
would keep
just
the patient on a gluten-containing
on a
diet.
gluten-containing diet it's for a potential celiac disease with no symptoms. In diabetic, it is really controversial, but still we have to stick to this advice.
Yes. And after how many times do you recheck the serology? Can you advise us on this?
Well, the serology in that case you mentioned was positive. So the question should be how often do I scope the patient afterwards?
Yeah, scope the patient or look at the serology, how it's behaving.
Yeah, I would say on if I keep her or him on a gluten-containing diet after 6 months could be reasonable to scope. After 1 year could be reasonable if no symptoms arise.
Yeah.
This question is still a hot topic. There's a lot of discussion around diabetes type 1 and celiac and when to scope or not to scope or repeat the serology to these children.
Yeah, we had a webinar on type 1 diabetes and celiac disease. So maybe we should do another one in due time. Yeah. One more question for Francesco. How much gluten do you choose for a challenge? For how long at least? So a little bit more scrutinized, Francesco. Yeah. How much and how long at least?
I will start with 5 grams standard dose in children, and then if nothing happens, rise up to 10 grams per day, which is still a high amount per child. And I will keep the gluten challenge as long as possible, checking serology after 1 month and then after 3 months. But ideally, after 3 months on a 10-gram gluten day, you have all the good chances to get mucosal relapse. So it could be a good time to scope after 3 months.
But if the serology is negative, do you scope then?
If the serology is negative, completely negative, I will base myself more on symptoms. Then we have the very unlikely chance that we are dealing with a seronegative celiac patients, and it depends.
You would continue probably the gluten challenge or the gluten-containing diet,
I would continue the gluten challenge, and depending on the situation, perhaps a biopsy after 6 to 12 months could be reasonable.
Reasonable. Yeah. Okay, so probably that is it then. I don't see any other questions coming in. We are thanked by the audience. Very interesting discussions. And I wish you all a very pleasant evening, and maybe we'll see each other in a future webinar on celiac disease or any other topic. So have a nice evening, everybody.
Yep.
Thank you. Bye-bye.
Bye-bye.